I'm the Senior Vice Chair of the IRB, which means that when Dr. Rosenthal's not around, I'm the one who is responsible for taking care of all the headaches and issues and things that come up, making decisions, stuff like that. As part of the structure, we meet on a weekly basis, or mostly weekly basis, with Dr. Gerald, who's the Vice President of the campus, and also the Dean of the school, the graduate school. And so I've been doing this now for probably, well, I've been on the IRB for 13 years and Vice Chair off and on for the last 10 years, and have presented at other institutions related to various topics related to research and research ethics. So I've been doing this for a little while and have a little bit of experience and knowledge, particularly about our institution here. But before I get started talking about my stuff and what we're going to talk about today, which is to help you get through your IRB protocols through the IRB, the first question I have is, who's everybody here? So how many of you are investigators, principal investigators, faculty, those type of folks? Raise your hands. So we've got a couple. How many of you are study coordinators or others? So some, okay. I know I've got IRB folks out here in the front, so they're going to correct me when I make a mistake, or at least nudge me afterwards. What else? Anybody else here in terms of other kind of roles? IRB members, I see. Any other roles that I should know about? What? Center for Clinical Trials. Okay, good. Anything else? Okay, great. So what I'm going to do today, what I'm going to try to do is help you do what you need to do, which is to get your research done. Okay. One of the steps in doing research, there's lots of steps in doing research. You got to get your funding, you've got to put together the protocol, you got to put together your team, all those different components. But one of the important steps is to get it approved by the IRB. Now, why do we have IRBs? Well, unfortunately, I'd love to say we didn't need them, but and previously there were any number of experiments done by the Germans and the Japanese and others on human subjects without consent. A lot of the things that we look at now relate to the fact that research was being done in what we would consider now unethical ways. So one of the first things to consider is that you have to have voluntary consent. The experiments they did on humans in World War II, there was no voluntary consent. You'd throw them out to see how long it would take them to freeze to death, those type of things. Okay? You have to make sure there's no coercion in the informed consent. Okay? Subjects must be able to stop. So a lot of this relates to the autonomy of the subjects and their ability to say yes or no in terms of their involvement. Okay? Ideally, there should be prior animal data. Now, that's not always true, but particularly in greater than minimal risk, you want to have something to support the reason that you're doing your research. Okay? You want to make sure that the anticipated results justify the risks, so risk-benefit, which you'll hear me speak about quite a lot throughout this presentation, and that you want to minimize any type of harm or suffering of the subjects. Now, hopefully, if you've gone through the whole process of getting funding and everything else, these things have been made relatively clear that you've looked at and considered these components as you put together your research proposal. But, again, these are things that you need to consider, that we consider as we put together and review the IRB proposal. So some of the lessons learned was that there's a difference between medical practice and research. In medical practice, I can say, as a physician, I think this medication works really well for this. It's not what's labeled, it's an off-label use, but I can make that decision and make that recommendation, and you as a patient can accept that. If I'm doing research, and this be very clear, whatever you put in the protocol is what you need to follow. By federal regulations, we as an IRB need to know what we're approving. So if we're approving something, it doesn't mean you can go off-label of what you've had approved. But in medical practice, I have a lot more liberty. Okay? Research lies outside of that context. Okay? It's the physician, there's a physician or researcher-subject relationship, but it's not necessarily the same as the patient-physician relationship. Okay? And your primary goal is you're really trying to test a hypothesis. Does X drug improve Y condition? Okay? But within that context, you have to be aware of what's happening to the subjects. So this is kind of what came out of Nuremberg in the 40s. And you would think, okay, great, we learned a lot from Nuremberg, we're going to do a better job. But how many of you have heard of the Tuskegee syphilis experiments? Okay, I think almost everyone should know about this because it dramatically changed the environment here in the U.S. and I think globally for research. It also is set up a lot of what happens in terms of IRBs and subsequent things because of what happened. So in brief, the Tuskegee syphilis experiments is when they started off by, at the time the research started, they didn't have good treatment for syphilis. So they chose poor black men in Tuskegee, Alabama, to study the life of syphilis, what happens when someone gets syphilis, which at the time was probably ethical because they didn't really have good other treatment. Well, along came penicillin, which syphilis is exquisitely sensitive to penicillin, so it was treatable. And did the researchers give the patients that treatment? No, in fact, they actively avoided giving them that treatment. They did LPs, which the patients thought would help in terms of clinical treatment. So they did a lot of things that we retrospectively were aghast at. They really did non-ethical research from our perspective. And who are they? This was the federal government. This is the CDC. So you would think that there was some knowledge and some thought, but again, things from 32 to 71, when this came out, a lot of things had changed. Okay. So what were the ethical issues here? Inadequate disclosure. Okay. They thought they were getting free treatment, that spinal taps were part of that treatment. And it was only after it came to light in 72 that this research was stopped. So what was the U.S. response? The U.S. response was what became known as the Belmont Report. And the Belmont Report is really the critical component of what the whole federal regulation then became based upon. Okay. So in the end, as a researcher, you have to balance two components. The first is the advancement of science, okay, versus the rights and welfare of the subjects. Okay. And if you take a look at this, very intentionally, this is the weightier of the two. Okay. That's my job. That's our job in the IRB, to make sure that what you're doing is ethical, and then what you're doing is not going to cause harm to the patients, or the risks related to that research are less than the benefits they're likely to get. Now, let's be frank. Every patient, every research is different. Okay? Patient subjects are different. So we'll do research on like phase 1 clinical trials of medications which will likely kill somebody. But they're going to be in a population that's dying of cancer. So they're willing to take that chance that this may end their life a little sooner because it may advance science. But we couldn't do that research in another population because the risks outweigh the benefits. So every research protocol has to be looked at individually. There's no global approval for research. Okay. So I just wanted to put that all in kind of as a quick background to understand why we are where we are at this point, which is the federal government has devolved the approval of research at different sites to those different sites. So in a way, we function as a regulatory arm of the federal government. Now, I don't know about you, but I'm not real into regulatory arms, IRS, things like that, but it is a requirement, and we want to make sure that research is done ethically. Now, the additional component that we want to add to that is to make sure that we help you do the research the best you can. So a lot of times we'll ask scientific questions if it's not clear to us, because we have to have clarity as to what you're doing. So while we're regulatory, it doesn't mean that we're not friendly. We try the best we can to help you and to have a conversation, have a dialogue, to help you put your stuff through so that you can get the approval as quickly as possible and as efficiently and effectively as possible. So let me talk a little bit about some nomenclature real quick. I'll put all these things up here. IRB is Institutional Review Board. I kind of view it as the judicial branch of this whole process. Okay? The overall program is the Human Research Protections Program, and it involves the Human Research Protections Office, which does relates to a lot of the administrative stuff back and forth, but they have other very important roles, such as looking at doing site audits and things like that. And then, as opposed to the Human Research Protection Plan, so the HRPP includes the HRPO and the IRB, And then you have the OHRP that comes and visits, and the AHRP as well. Yes, it's all very confusing. The bottom line, Human Research Protections Program involves the Human Research Protections Office and the IRB. IRB is the judicial component. The Human Research Protections office is kind of more the executive. They're the ones that deal with a lot of those things. OHRP is the federal government that oversees this whole process for all the institutions in the country. And AHRP is an accreditation body. So it's independent but an accreditation body. So we're an accredited plan, program, and IRB in this whole process. Okay. So just so you're clear, a research submission is not an IRB. An IRB is a committee that comes together and makes a determination. Now, is the language a little lax sometimes? Yeah, I put an IRB in. Yeah, well, but just be aware that your research protocol is a protocol. You could have a protocol that's done as part of a grant, and then you put that into the Cicero protocol so that we can see it. But these are all different, slightly different components. Okay, clarity. As I tell my residents when I'm teaching in the emergency department, we have to be clear with our language, okay, because we're communicating with each other. So you want to make sure that you use the language to the best you can and properly. So a protocol, a research submission is not an IRB. It's a research submission. Okay. And as we already talked a little bit about, medical practice is different from research. Experimentation is different from medical practice. I can do things in medical practice based on what my belief is the best for the patient, but in an IRB protocol with an experiment that involves human subjects, we have to follow what's in the protocol. Okay. If you're not sure, ask. If you need to do something that's different from in the protocol, you have to get permission. So be very clear that what's in the protocol is what you're going to be held to. So if you say that you're going to do a follow-up visit at 21 days and you do it at 22 days, that's a protocol. That would be what we used to call a deviation. Okay. Now, if you say you're going to do a follow-up visit between 20 and 22 days, and you did it on 20, 21, and 22, that's in the protocol. Okay. So those are the kind of things. But we, as a regulatory kind of function, need to know what we're approving you, and we have to make sure that you follow those approvals. So that's why it sometimes feels very picky. But again, this is all part of the process that we live with and we want to help you with as much as we can. Okay. What's the definition of research? Because really that's a very key definition for this whole process. So research is activities designed to contribute to generalizable knowledge. Okay. One of the questions I get asked is, well, we're just doing a QA project. Okay. What's the difference between a QA project and research? I'm asking you guys, and it's time for me to get a little audience participation here. So what's the difference between a QA project and research? What?
Not generalizable.
So it's not generalizable. Okay, what does that mean? If I'm doing a QA project in the emergency department to see whether or not I can improve patient flow in my emergency department, and I'm presenting it to my colleagues from my emergency department, that's a QA project. If I'm going to do the very same project and plan to publish it as a poster or an abstract or in the peer-reviewed literature, that becomes research because I want to extend it beyond the group that's involved. If you're not sure, it's better to ask in advance because we cannot retrospectively approve research. Okay. In general, with research, you're testing a hypothesis to draw conclusions. It's described in a formal protocol. One of the things that often happens, especially by folks who've been doing this a long time, and so they're a little more gray-haired, shall we say, and haven't kept up, they'll often blur practice and research. Okay, that's not that. Again, you're deviating from your research protocol. That's where you get yourself in trouble. That's where the IRB, they're actually Human Research Protection Office will come in and audit when they start finding concerns for that. Practice and research are different. They can occur simultaneously, but they're different. Okay. Another important definition is what's a human subject. So a human subject is where you're getting information either through some type of intervention or interaction with the individual, or you're working with identifiable private information. So based on this definition, okay, if I'm doing if I'm going to do research on cadavers, would that be human subjects research? You guys can't answer. You guys know the answers. So you guys, I'm asking the rest. No. Well, it depends. And I'll say why. If all I'm doing is taking organs out, I don't know anything about this subject, there's nothing there, okay, then that's not human subject research. If I'm trying to get data about them, then I might run into some kind of differentiation between that and HIPAA, so that's where it gets a little more blurred. But in general, if you're talking about cadavers, that's not human subjects. They passed away, they're no longer living. The data issues become a little more blurred, but as a general rule, the answer is no. Okay. Again, what are the risks? What are the benefits? Are they spelled out? Every review I do, pretty much, I'm going to say the risks are this. Minimal risk research, risk is loss of confidentiality. The risks are minimized by using a de-identified data set. The benefits, there are no direct benefits to the subjects. However, there's potential for societal benefits. That's imprinted in my brain. I just did it this morning on another protocol. So that's the type of thing that I look at. Okay? If it's a greater than minimal risk, then you need to be able to define what are the risks, how are they going to be minimized, what are the benefits, and is that risk-benefit ratio appropriate? The clearer that is, the better it is for us in terms of a review process. Okay? Again, benefits need to exceed risks. So let me talk a little bit about kind of the whole process here. So you've got the Human Research Protection Program, the Office, and the IRB. Okay? This is probably a little bit of an older chart, but to give you an idea of kind of the structure, people do change at the HRPO, so the best thing to do is when you look at Cicero is to find out who your coordinator or administrator, whoever it is that's listed on that, so that you can be able to contact that person directly. And the one thing I would say, yeah, this is quite a bit older. There are different components. So there's both the kind of review process as well as the review process or the audit process. Okay. We see roughly about 2,000 protocols a year. Majority of these are minimal risk, so they go through an expedited process. However, we do have meetings on a regular basis to look at greater than minimal risk protocols. The mission here, and again, what we're trying to do is to protect the rights of welfare subjects involved in research that is overseen by the organization, and to foster a high caliber of research environment. We really want to support the investigators as long as we're recognizing that our primary responsibility is to make sure that we protect human subjects. Okay. So what do we do at the IRB and the HRPO? What are the things that we look at? So we look at review protocols, and these are new modifications or amendments. Those are the same terms, renewals and reportable new information. HRPO organizes the IRB meetings. They monitor and audit, and we involved in the education of the research community. Okay, and this is kind of the whole research program. As you can see, it's quite complicated. It involves Dr. Jarrell, Dr. Rosenthal is the chair, Susan Buskirk, a number of different people. Okay, so this is a whole infrastructure to help support the research that you're doing. Okay. I've already covered most of this already. This is just a definition of the IRB. The one thing I would add to what I've said about the IRB is that there's a couple of different categories we need to include. So we have to have our scientific reviewers. We have to have a non-scientific member, and ideally we have a community member. Okay? But we cannot have a quorum unless we have that non-scientific member. So someone who's not a scientist. What's not a scientist? Well, it could be a librarian from the library. It could be a lawyer from the school of law. It could be someone from the community who's or a rabbi, minister. We've had a number of different people. The other thing I would say also, just to be aware, is that, and it's not here, is that if we're doing VA research, we have to have a VA representative. Okay. And ideally, when we review research, we like to have someone with expertise related to that topic. So if we're doing children, we like to have a pediatrician or someone who knows pediatric research. If we're doing cancer, and the cancer studies can be very complicated, it's nice to get an oncologist there. Okay? So we tried very hard to make sure that your protocols are being reviewed by both lay people or people who are non-scientists that have some knowledge and experience related to research or research ethics, as well as scientists who are going to understand. Now, does that mean we get it right all the time? No. But that's where the conversation comes in. This is a conversation. This is not, you'll do this, you do that, but we need to make sure that we're telling you what needs to be done in an appropriate manner. Okay. And this is the IRB leadership. This is Dr. Rosenthal, chair. In the leadership, he's in emergency medicine, but he's at shock trauma, does hyperbarics. I'm both emergency medicine and epi. Jim is a person who's done pediatric research and has done a lot of international stuff. And the rest, we have psychiatrists, cardiologists, infectious disease people, dental. So we have a relatively wide range. Now, we're always looking for new members, both in terms of the IRB as well as the leadership in the IRB. If any of you are interested, I'll put a shameless plug in. If you're interested in being on the IRB, it's a great opportunity. You learn a huge amount by reviewing other people's research, both good and what are they thinking, So if you're interested or other people who are interested, particularly non-scientists and VA members, we're always struggling to find folks like that. So I'll put a shameless plug in right now. If you know someone, let us know. We'll be happy to go talk to them. Okay. So you've got a protocol, or your PI has a protocol. You've put it all in, you've answered all of it, you checked all the boxes, and you send it in to get it reviewed. So what's the process? After you've completed your protocol, it doesn't come to us. It goes to your departmental reviewer. Okay? We'll often get yelled at because it's taken so long to review it, but then when you look at it, the departmental reviewer held it up for 3 weeks or a month. Okay? So recognize that the first step after you hit that submit button is not to us, but the departmental reviewer. In addition to the departmental reviewer, it may go to a secondary department. So if I do emergency medicine research, and I may be doing pediatrics at that, then it may go to pediatrics for them as well. Once they've reviewed and approved it, it then comes to the IRB, or the HRPO actually, and to get it reviewed and put together. And there may be some queries back and forth administratively to make sure everything's put together. The departmental review is supposed to make sure that there's adequate support for the research and that scientifically it makes sense. I'll be frank, some of the departments do a better job of reviewing than others, so there may be additional scientific questions. Once it's gone through the departmental review, the pre-review, it comes to the IRB for review. Now, how frequently do we meet? We meet a lot. In the old days, we met once a week, and if you got something deferred, it could take a month and a half or 2 months to go back there. We now have roughly 3 meetings a week. These meetings are 2 hours long. We try to be efficient and effective and get through everything. At the meeting, there's going to be there's going to be modifications, there will be renewals, there'll be reportable new information. So they're relatively full meetings. Okay? But if you've got a protocol that gets deferred, we can bring it back the next week. We can bring it back within usually 5 days or a week once you've finished whatever those deferral issues are. So the fact that it gets deferred is not necessarily bad. What's important is to make sure that you respond to the deferrals. We can't approve something if we don't know what's going on. If we say, please clarify, as soon as we use the word clarify, it becomes deferred because it means we don't know what's going on. If we can tell specifically, say, please insert this language, you have, in one place in the protocol, you say you're going to be enrolling 30 subjects. In another place, you say 40 subjects. We've talked to the principal investigator. He says it's 40 subjects. Please correct this area. Those are the things that we can say modifications required to secure approval. But if we don't know, then we have to defer it. Already talked a lot about the various folks on the meetings. Okay. So we have 3 meetings a week. If we're doing 2,000 protocols, I think we'd all pull our hair out if we had to do it to every meeting. So we've developed an expedited process. And let me take a step back. If you go into your research, there's kind of 4 categories it's likely to fit into. Okay? First, it may be non-human subjects research. You submit a brief letter that says, this is what I'm planning to do, and then you get a response back that says non-human subjects. You're done. That's it. What's non-human subjects? If I want to look at the ambulance traffic in Baltimore City and I want to see whether or not weather impacts ambulance traffic, I don't care anything about the people in the ambulance. I'm just looking at the ambulance system itself. That would be non-human subject research. I'm not looking at the level of the person. Now, I could do the same research, but I want to see patient outcomes. That would be human subjects research. Okay? So what I look at is what's the level of analysis. If the level of analysis is at the human subject, then it's human subject research. The next level above that would be exempt. And there are specific criteria for exempt. We can look them up. But essentially, it's going to be de-identified data. There are specific categories. When we look at exempt protocols, most of the time it's doing research on data that is either publicly available or is done in a way that you cannot identify the individual, and it's retrospective. So those are our exempt protocols. The advantage to exempt protocols, it means it doesn't fit the other IRB regulations or rules, and you're done. The disadvantage to the exempt protocol is that you cannot go back to get more data on what you've collected. What do I mean by that? You can't maintain identifier. If you have an identifier, then it's no longer de-identified. So if you do it exempt, I'll often recommend that people do it as expedited instead of exempt if they want to collect additional data. The next level above that would be expedited. And we'll talk a little bit more about that. The difference between full board and expedited from a process perspective is that it'll come to a vice chair or a designated reviewer. They can review it and approve it, and then it gets recorded on the minutes of a meeting, as opposed to going to a full meeting where there's a discussion. What are the type of things that we see here? You've submitted a protocol modification to change the number of subjects in your study. You're changing the personnel in your study. Your study is greater than minimal risk, and you're now adding a new point of contact or something like that. Those still need to be reviewed as modifications, but they don't need to go to the full board. So it has to be minimal risk or a minimal risk change on a greater than minimal risk protocol. And then and there's some other criteria, but that's essentially what we're looking at for expedited. Finally, there's full board. And full board are the ones that, those are greater than minimal risk as a general rule. They're interventions. There's a lot more in the full board. So recognize that as you put the protocol in, it has several different routes it could go. Okay. I've already talked about this. Levels of research. So what's the definition of minimal risk? This is right out of the Code of Federal Regulations. And essentially, it's the probability and magnitude of harm or discomfort anticipated in the research are not greater in and of themselves than those ordinarily encountered in daily life or during the performance of routine physical or psychological examinations or tests. So it must have been written by either a committee or a lawyer or both, right? You're doing surveys of individuals. You're going to do a single blood draw. You may be doing physical exams in a normal population. These are things that we would do. You're going to do a retrospective. You're going to do a chart review of people. These are the type of things that we would consider minimal risk. If you're doing any type of intervention, you have to question whether it's minimal risk or not. It depends exactly what that intervention is. But as you do more and more, it becomes greater and greater. But essentially, it's what you would see on a daily, just daily life. If you go to see a doctor, it includes a blood draw, but it doesn't include an IV. So once you start thinking IVs and multiple blood draws, that tends to bump it up to greater than minimal risk. Now, there's slightly greater than minimal risk and then much greater than minimal risk, and those are other kind of conversations to have. But in general, expedited have to be minimal risk. Okay. Chart review, survey, blood draws, analysis of previously collected specimens. Talked a little bit about exempt. Mostly it's category 4, which is retrospective chart review. I talked a little bit about this. Like I said, the slides are less important. It's, and I'm going to try to get these slides put up on the website at the HRPO so that you guys can access it if you want. Okay. Talked about this. I'm going to stop here for a second, even though I've covered most of this already. What are we looking at? Okay. is, when I do my reviews, what am I looking at? So you want to make sure that the subject is adequately protected. Benefits are greater than the risk, study design and scientific integrity of the research, no coercion, privacy and confidentiality, and data and safety monitoring. So let me ask a question for everyone. What's the difference between privacy and confidentiality? So privacy in general, we're looking at how did you enroll. It's in a private location. So you're having a conversation about the research. It's not going to be overheard. Okay. Confidentiality in general deals with the research data and the data that how you're going to maintain. So in a retrospective chart review, which of those are you concerned about and which one are you not? For a retrospective chart review, are you worried about privacy or confidentiality? Thank you. So just so you be clear that that's what the difference is. So if we're going to talk about privacy, when it comes up, you say, how are you going to address that? If we talk about confidentiality, how are you going to address that? So standard answers for confidentiality, for example, are it's going to be kept in password protected, computers or paperwork is going to be kept in file cabinets in a locked office. They're not going to leave the institution, et cetera, et cetera. The issue of confidentiality is huge. Anyone who's done VA research more than for a couple of years recognize how critical confidentiality has become and maintaining data security. But you also have to be aware of the privacy component. One other question. Do you need a data and safety monitoring plan for every research project? Okay. What was that? No? Is that what I heard? No, yes? Okay, let me ask. How many here think that you need a data safety monitoring plan for every research project? How many think that you don't need a data safety monitoring plan for every research project? About 50-50. The answer is you don't. Okay? But if you don't have one, you better have a good rationale. I'm doing a retrospective chart review with a single data pool. That data is going to reside in a confidential, that probably doesn't need I need to report back to the IRB once a year to say that we didn't lose the data. Now, if you lose the data, you need to report that. However, if you're looking at anything greater than minimal risk, if you're looking at most interventions, then you need to be, even blood draws, you need to be able to say that no one passed out, from the blood draws. It happens, especially young, healthy teenage boys seem to like to pass out, but that's a whole different conversation. So the answer is no. Think about it, because if you say you're going to report 3 times a year, then we're going to expect you to report 3 times a year. If you say your next data safety monitoring meeting is February 2015 and your renewal is in April of 2015, we're going to ask for that data safety monitoring, or you're going to have to explain to us why it's not there. Right? Had one recently where they said they were going to have the next data safety meeting after 100 enrollees, and they said that, well, they'd enrolled 150 or whatever the number was, 120. And so we asked them, where was the data report? And the answer was that those who had enrolled had not really been engaged in research. They had met one level but hadn't gone to the next level, so they didn't have 100 people yet. So there was a conversation there for them to explain to us why they had not reported, and that was their rationale. So here's our list of things to look at. Okay, now do we do a checklist on all this stuff? We have checklists and worksheets. Worksheets help us. Checklists we have to complete. So a lot of these are on our checklist. Risks to participants are minimized. Risks are reasonable in relationship to associated benefits, anticipated benefits. Selection of participants is equitable. Had a protocol come in the other day that said they were only going to enroll Caucasian men. Okay, I don't have a problem with that, but you better explain to me why Caucasian men are the specific group that you want. Why are you excluding women? Why are you excluding other races? Okay, if you can come up with a good scientific rationale and not just convenience, then that's something that we can talk about. But the selection, and there's others. There's a whole issue of societal justice. So if you're doing research in a lower socioeconomic community, then you better be able to say why that research, make sure that the benefits of that research also goes to that community. It's particularly important once you talk about international work. Informed consent will be sought and obtained in the appropriate manner. How many of you have seen like a full board IRB consent form? I think the longest I've seen is maybe 35 pages. It's too much for me. It's like a small book in language. It's supposed to be readable. For us, what's important is what's the consent process? You're doing research in cancer patients. Those are often, again, are very complicated, long consent forms. Are you sitting down and talking to them in a private manner so they can understand? Okay. Do they have an ability to review the document and ask questions afterwards? Is there an ongoing process to make sure that consent is maintained? Because consent is just not a single event, but it's an ongoing process. So for us, when we look at consent, it's not just the elements, but how is the whole process of the consent being done? There's provisions for obtaining that you obtain a document informed consent. How many of you are familiar with Cicero, the Cicero doc? Okay, we'll get there in a second, but a lot of these, you'll understand why those questions in there. Privacy and confidentiality are adequately protected. Research plan has provisions for data safety monitoring, if applicable. Additional safeguards are there to protect rights and welfare of vulnerable populations, if applicable. We talk about vulnerable populations. You'll hear us talk about Gen 2, which is the second generation of the Cicero application. In Generation 1, there were a lot of different categories. Now, we've pretty much honed it down to specific categories. Pregnant women, human fetuses and neonates, prisoners, children, cognitively impaired, students, employees, and wards of the state. Each of these are a little bit different. There are different criteria for all. One thing just as a comment, how many have heard of Kennedy Krieger? The Kennedy Krieger. Okay, so recognize that the rules here for us in terms of children are slightly different. So we'll struggle with things that other institutions may not have to struggle with because of the state regulations. Because we still have to be responsible not only for the federal but also for the state. So what can we do in terms of the IRB? We can approve, disapprove, or modify research protocols. We can suspend or terminate. We can continue review. We can critique and monitor informed consent processes. And we can do audits. And one other component is we do have some conflict of interest responsibilities, but the institution has moved most of that to a different office at this point. I think I went through all this stuff. Okay, so Cicero is our wonderful electronic system for doing this. It's not always the easiest to navigate, even for me who've been doing it for a number of years. Having said that, it's really nice because if you need documentation, it's all there. It really makes sure you explicitly spell out. Often when I'm teaching junior researchers, I'll have them go and take a look at and make sure they understand the different components. So I think it's a good educational model as well. Now, let me ask. I can go into Cicero right now and spend 5 minutes just kind of going around a little bit. Would you like that? Or should I just continue with the presentation? No. I say no. Everyone's okay. Okay. We're happy to work with you on a one-to-one basis if you want to help with Cicero. When you're doing your protocols, if you have any questions, make sure you contact people in the office. The other thing to recognize is that we're now allowing that if you've got a written research protocol, let's say that you're doing industry-sponsored, that's very explicit, you can look at privacy and you can say, look at page such and such in the protocol. Okay? Just make sure it's clear in the protocol because the protocols are not always the clearest. Okay? So I'm going to skip that. A little bit more about PIs. PIs must be 51 and employed by the University of Maryland, or you need to get some type of exempt. You'd have to get Dr. Gerald to approve them otherwise. Okay. The Cicero submission created by the PI. First, everyone has to have appropriate research training. You can go on the website and see what that is. Recognize that the team will often put together the PI's, the protocol. The PI is really the one who should submit it. They're the one who has to review it and approve it. They're the one who's responsible for doing the research right. They play a critical role in this whole process. Okay, I already talked a little bit about the whole thing of scientific review. And again, make sure if there's a delay that it's gone through the departmental review. Okay. Talked about minimal and greater than minimal risk. New research coming in will have at least 2 reviewers if it's full board. If it's not full board, it'll usually just be 1. Okay. We talked a little bit about this. So let's get into some details. I think I've already said that enough times. Make sure you complete it. Don't leave them blank. If there's a question there and it's not applicable, just say not applicable, NA. Okay. But make sure that you've addressed it. The Cicero is a smart process so that if you answer a specific question, it'll lead you down a different algorithm. If those algorithms aren't right, then you may need to go back up to the STEM question to understand why you went down that way. Vulnerable populations and data safety monitoring. And procedural questions, so stuff on how to do things in Cicero should go to program staff. Questions about the research and research itself should probably go to the executive committee or the reviewers. So we all have to live with this. Talk with us. We'll work together. I mean, the idea is that this is a conversation. I've been asking you questions. You're asking me questions. The idea behind this is that we want to do this collaboratively and do the best we can to help you. It's bureaucratic. It's a process. It's open to audit. We've been audited as the program has been audited almost yearly for the last 10 years. Why? Because we're under the VA. We're under the HHS. We've got accreditation bodies. There have been whistleblower complaints, not against us, but against research. So we've become, and I'll be frank, we're relatively conservative when it comes to these things, but we've managed to make it through every one of our audits. What you don't want to have happen to you is what's happened to other institutions where they've closed down the research for several days, because that impairs your ability to do research, impairs the funding stream, which is very important to the institution. So we want to make sure that we do it right. I want to help make sure that you do it right. So to be clear, that's kind of our perspective on all this. The principal investigator is the critical linchpin to all this, okay? We're basing our review on what you've put into that protocol. If you're not following that protocol, we may or may not find it. But if we come to audit it and find that there are problems, that's when things get a little bit more stressful. We talked a little bit about other departments, but there are other places in the institution that will have to review the protocol as well. So if you're doing anything with radiation, in terms of x-rays, then it has to go to radiation safety. If you're looking at environmental or dealing with bloodborne pathogens, it has to go to environmental. There's a number of specialty reviews, pediatrics, cancer center, etc. I'm going to skip through this. These are just, again, just listing, and we'll try to put these on the website. And I'm going to stop here to see if there's any more questions. This is an introductory lecture. And by that I mean it's really just to kind of give you a sense of how the whole thing is put together. Just understand what we're trying to do and why we're trying to do it, and to understand that we're not there to make your life miserable. We're there to help you as best we can, but we have to do this within the federal regulations. I have a pet theory that, historically we were responsible for many things, but when it was all paper-based, it was harder to review stuff. So, you might get audited now and then. But as we got computers, we're much better able to put all the data into computers. So now the expectation is that all those federal rules and regulations that have built up over the last 200 years, we're now responsible to show documentation that we actually are meeting all those. So I think the regulatory burden, talk to faculty, I'm sure you're aware, in terms of effort reporting, in terms of all those things have become much more, a lot more work. We want to minimize that work, but we still have to do it in a way that's going to allow you to do the research and for all of us to be within regulatory compliance. So I think I'm going to stop there. We have a couple minutes for questions, and I'd like to go ahead and open up to you. Please go ahead.
Hi, very, very nice, simple presentation. I'm in cardiology, and I'm getting a lot of interest from nurses coming up with really good research ideas. The problem is, I hate the fact that they can't be a PI, even though it's their idea, their protocol, and they're managing it. Can you speak to that?
Sure. So the institution has decided that you have to be a certain level of faculty. Now, if you're working with nurses, there's a whole school of nursing. The School of Nursing, we have multiple nursing PIs. But there's a difference between the clinical realm versus the faculty realm. And so the key would be to find a partner which they could work with, perhaps at the School of Nursing or at the School of Medicine. But the decision has been made by the institution that they have to have that type of faculty relationship. There are rare exceptions, and I'll underline rare on that, but as a general rule, that's the expectation. But again, nurses can be PIs, they just have to be faculty nurses. So.
Right, and like you said, these are clinical nurses
Right.
that had their BSMs and whatnot.
Right.
All kinds of.
But there's great researchers in the School of Nursing, so you can look for them as well. And simply because being the PI in the protocol, you're the one responsible from an institutional perspective, but you can work closely with someone who's developed the idea. So a lot of faculty will have their fellows be doing research. The faculty is the one they're the one held responsible. The fellow may be doing the actual research, The PI is still responsible for what the fellow does, but the fellow is doing the majority of that retrospective chart review or whatever else. So,
or they want some credit.
they can get the publication from the institution is really a credit perspective. So, but yes, I understand what you're saying. Other questions? Go ahead.
How long should we expect reviews to take for amendment for expedited protocols that are undergoing expedited review versus the ones that are not going to do expedited
Right.
review? This is a recently taking a lot longer, and what can we do to speed up?
Right. So we're very frank about our metrics. I've been to a number of other human research protection programs around the country, and it's not always easy to get their metrics. You want our metrics, you go to our website, they're right there on it. And you'll see that our review times, as a general rule, are much better than industry average. Now, having said that, we've had some staff turnover recently, and so things have slowed up a little bit. And it's kind of episodic. Sometimes they slow up, sometimes they speed up. Usually within a couple weeks, particularly for the minimal risk and modifications that can go expedited. We're a little bit backed up, but we've done some different processes in the last 10 days to try to improve things. If it's urgent or there's a problem, just notify, touch bases with the administrator or the person who's listed on the protocol, and they should be able to help you. We try not to make anyone special, so just simply because you're the dean of the school of whatever doesn't mean we're going to make anyone special, but we do try to respond as quickly as we can to all requests. Go ahead.
And you may not be able to answer this, but we're starting to see, you can look at your metrics, and I look at metrics all the time, and we're seeing more and more proposals go through, funded, and some investigated or initiated, because that's how really R01s are funded these days. You have to use those pilots and all that. So the question, as a general rule, is does Human Research Protections Office have the infrastructure to grow accordingly as the university research enterprise is growing accordingly? We're going to see things. I mean, in cardiac surgery, we have 9 or 10 studies just kind of just sitting there waiting to get put through because we're limited on staff. But is there the infrastructure there to grow?
Yeah, we have this. The answer is yes and no. So we have a structure which is adaptable and modular, so we can grow as necessary. But then we have to have the institution to give us the resources to grow from personnel. We're down right now, so as soon as we, if we get fully staffed, then we can talk about growing beyond that. But it would depend on the level of demand. So the answer is yes, we can do it, as long as we can get the institutional support to do it. But I think part of it is for us also to be as efficient and as effective as possible from a process perspective. Go ahead.
Who is currently responsible for uploading approved VA consent? I heard a rumor that it will go back to the IRB.
Yeah, you guys want to answer that?
One of you may have talked.
We actually just this past Monday, it changed. So for new protocols that go through the VA is still responsible for stamping those consents. The purpose of that being the R&D committee review. But for continuing reviews and modifications, the HRPO will be stamping those. Yeah.
And I think that's a great question because it shows the complexity and the changing nature of this. One of the other things with the fact that we're now being asked to document so much is also the fact that things are not static. So be aware that things change. If you have a question, ask. I think with that, I'm going to go ahead and stop. We're just about out of time. I very much appreciate your attention, and feel free to come down and ask questions or contact the office if you have anything. So thank you very much.